Good morning.
Morning.
Hi, Maya, Christina, Ivana. Let's give it 2 minutes and we'll get going. Okay, I guess we'll get going. All righty. This is a 12-year-old patient whose ECG was obtained during evaluation for psychiatric medication, something which I'm not in favor of, nor am I sure there's any evidence for, but and I will also show you that on another day, this is the same patient's electrocardiogram. So this was obtained like 6 months earlier when psych meds were begun. And this was the ECG obtained after psych meds were begun. So what do we think, Christina? What's our concern, or what do you make of this observation or finding?
I think with any psychiatric medications, there's always concern for any QT prolonging. And in this patient, you know, with you showing me the prior EKG 6 months prior, it relatively looks, oh,
Sorry, there it
it
is.
look, looking at it, it looks relatively normal,
Mm-hmm.
except for some QRS widening in V4 through V6.
Mm-hmm.
And then you go back to the EKG now that the patient's on these medications, and just diffusely across all the leads, it looks like there's QRS widening throughout
Any thoughts on
all the
why the
leads.
QRS is widening?
I think there's a side effect of whatever medication that the patient is on. Just
Well, okay, so as I said last week to Katoki, now that you've been practicing as a pediatric cardiologist for 8 or 9 months, you have to start asking yourself, have I ever seen a psychiatric medication cause a widening of someone's QRS or even heard of that? And the answer is no. I know you haven't because I haven't, and I've been practicing for 25 years. So, what do you think? What do you think is the mechanism for the widening of this QRS? Is there a P wave before each QRS?
no, there is not. In 1, 2,
Well,
and AVF, I
well,
do
what
not.
about in some of the other leads? That's why you have a whole 12 lead.
Yeah,
What do you make of these leads or even these leads?
yeah, those look like um, P waves, and so
Or what about in the rhythm strip here?
and then in the rhythm strip as well.
So do you
Um,
want to retract your comment that
yes,
it doesn't appear as if there's a P wave before every
I
QRS?
I will retract my comment.
Okay.
Uh, but and looking closer now, it looks like it's more of a delta wave
Right.
um, that I
Right.
see.
Yeah, you even yourself said that in the one that does not look as if it's pre-excited, you said that in V4 to V5 that the QRS
Yeah,
was widened. And I think in retrospect, you could say that there is actually pre-excitation.
yeah, correct.
Okay, so do you think
So
it's the Do you believe it's the psychiatric medication that is the cause of the pre-excitation?
No, no. I
Oh.
think the patient has WPW, which could be
So
causing this.
how would we describe it if on this EKG we see it, but on this EKG we do not see it?
Um, that there's different accessory pathways, and so this EKG, obtained previously did not show it as diffusely as opposed to this
So if
EKG.
somebody has manifest pre-excitation on one day, but then on another day is not manifestly pre-excited, is there a term we use to describe this form of pre-excitation?
In intermittent preexcitation.
That's exactly right. So this is an example of intermittent ventricular pre-excitation. Okay, so the first question that you're asked is, are you okay with starting some QT prolonging psychiatric medication? Obviously, the medicine isn't being used for this reason, but that is a potential side effect of the medicine, a modest prolongation in the QT. Any concerns with that?
Yes, I would be very concerned if the patient were to start it because, it would have an increased risk for torsades and sudden cardiac death.
Actually, turns out there's almost no evidence of that. Um, we psychiatrists are very worried about this point, but in fact, it's very uncommon for. In fact, I don't know that there's any evidence at all that WPW is any more of a concern than anyone else. When you are pre-excited, your depolarization is abnormal, and so your repolarization will similarly be abnormal. And so your QT may be a little longer when you're pre-excited. So I guess you could make an argument that pre-excitation marginally increases your risk for problems with a psych med, but we would not in general disallow this type of medication in someone whose QT interval was normal. And again, when we have the non-pre-excited electrocardiogram, we see that the QTC and the QT interval is very normal. So what about stimulant medications and WPW? That seems to be a more common thing. Those of you who've been in clinic with me probably have seen that at least every week or two, I see somebody who was diagnosed with WPW, and there's a concern about potentially starting stimulant medicine. What do you think about that and WPW? Any concerns there? Or?
I would be concerned with stimulants. And also increase your risk of having a SVT.
Well, again, it's one of these things where it makes theoretical sense that it might, but there's almost no evidence at all for that. And so basically,
It wasn't too bad, but I was driving a fair amount of the
hey,
point.
Howie, I think if you could
It's
mute,
pretty nasty.
hey, Howie, I don't know, maybe I'll mute you, actually. I can mute you. There you go. So yeah, it turns out that there's almost no evidence at all that pre-excitation enhances the risk of problems with stimulant medicine. Again, it makes sense that it might, and perhaps it does, and maybe it's just, it's not something that's been studied carefully and critically, and it might be true that if you had, 100,000 patients on and off the medicine who had WPW, that you would see differences in arrhythmia likelihood, but there isn't actually any strong evidence for it. Years ago, some of you have heard me tell the story that when I was working at Columbia, over the course of 10 years, I ablated maybe 10 or 12 patients in whom a stimulant medication was being considered. And in every case, we ablated the patient because of clinical indications separate from the psychiatric issue. I never have ablated somebody because I am worried that a psych med is going to cause a problem in a patient with WPW. But my former colleagues ended up writing a paper in which they essentially wrote that the reason or one of the rationales for ablating those patients was in fact, the presence of WPW and, shall we say, uncomplicating the management, the psychiatric management, by getting rid of the WPW. And they were very gracious in asking if I wanted to be a co-author on that paper, because the vast majority of those patients actually were my patients, and I had performed most of those ablations. But the reality was I asked them not to put me on that paper, even though it was very nice of them to invite me, because I felt like it was sending a message that I didn't want to send, which was that ablation of WPW is a reasonable or rational approach to somebody in whom there's an asymptomatic wolf, and you want to liberalize the ability to give psychiatric medication, particularly stimulant medication. And so the point I'm trying to make is I'm not aware of any strong evidence that it enhances risk. It might. I'm not saying it's not possible, and it sort of makes theoretical sense that a stimulant might enhance risk, but I'm not aware of any strong evidence to that fact. So I don't generally stop that. Now, let's take that off the table for a second. Let me ask Ivana. So, Ivana, now you have this patient, you have called the psychiatrist, you've explained to the psychiatrist that if you feel the patient needs this medication, you are not opposed to it. But what are you going to tell the family regarding risk? So this is an asymptomatic patient who has, let's say they have ADHD. They feel well, and this is the patient's ECG. This was taken earlier. This is one now. Is this patient, does this patient warrant any further testing?
Good morning, Dr. Paz.
Good morning.
I think overall, just based off this information, I probably want a little bit more data. First, I'd want to ask the family and the patient if he's ever experienced any heart palpitations, syncope, or anything like that, which would make me think he's more in the high risk group.
And they say that they have had he is completely asymptomatic, or she's asymptomatic. She's never felt anything.
Okay. I would probably then ask for a Zeo patch, just so I could see the degree of intermittent preexcitation over a longer course of time.
Okay, so you put a Zeo patch on the why do you want the Zeo patch? What's it going to show you?
So
Or rather, what are you looking for on it?
So I'm looking for any episodes of SVT. I'm looking for how often the child is pre-excited.
Okay, so you're looking for SVT because on the assumption that maybe the child is not
Mm-hmm.
recognizing it. That's very reasonable. So there is no SVT, and let's say that the child is a little uncomfortable with the monitor, so isn't really doing very much.
Mm-hmm.
And the heart rate varies from 62 to 105, and the child is pre-excited throughout.
So it sounds like normal heart rate variability. I think then you could also engage in an exercise stress test to see if, sorry.
I was just going to say that I would make the argument that in a 12-year-old, heart rate ranging from 62 to 100 is not a normal variability, right? Normally, a 12-year-old should be able to get their heart rate up in a day, normally at least the 140s, 150s, 160s, if they were playing sports, even higher. So it might be a normal or reasonable heart rate variability for someone who's sitting on the couch doing nothing all day, but probably I would, if I saw that on a Zeo, I would not probably comment on the heart rate variability, or I would say that it looked blunted. But okay, so right, so you don't see any loss of preexcitation, but the patient's maximal heart rate is only 105.
So then I would bring him back for a stress test to see when we exert him, just what his heart rate is.
Okay.
And then also if we continue to be pre-excited with that.
Okay, that's right. So let's look at the formal recommendations. And this is already an old paper, or an old statement, I should say, and it's came from 2012. And it is the PACES, which is the Pediatric and Adult Congenital Electrophysiology Society, and the Heart Rhythm Society consensus statement on the management of the asymptomatic young patient with WPW. And this was approved by, as you can see, virtually every major organization, including the American Heart Association, the American Academy of Pediatrics, some Canadian organization, a lot of different places, American College of Cardiology. And most of the individuals on this are prominent names in the field, including George Klein, who is the gentleman who did the first paper looking at preexcitation and rapid conduction. I think we've talked about him that in 1979, Dr. Klein wrote a paper in which he took a bunch of adults who had had a cardiac arrest to the cardiac cath lab and intentionally put them into atrial fibrillation, showing that a shortest R pre-excited R interval less than 250 milliseconds was associated with high risk. So anyways, this is actually the decision tree that is recommended by this paper and is still to this day the most commonly used algorithm for the evaluation of the asymptomatic WPW patient. And much of what you said, Ivana, is here. So you take the baseline electrocardiogram and it immediately separates the patients into patients with persistent manifest preexcitation or intermittent preexcitation. So our patient, I think we've agreed, would be the intermittent preexcitation patient. And so then the recommendation is follow in cardiology with counseling regarding symptom awareness. And that's where it stops. So according to this statement, which still remains the most up-to-date statement on this topic, this patient who is asymptomatic basically only warrants some intermittent follow-up and strong counseling regarding the importance of palpitations. Excuse me. Pardon me. However, sorry, if the patient has manifest preexcitation, then the recommendation is that the patient undergo the stress test, which is what you are advocating, Ivana. Although, again, I think you can see that, at least according to this algorithm, intermittent preexcitation, we could have stopped at that point. So this patient so then you would do an exercise stress test. And if there was an abrupt and clear loss of manifest preexcitation, you go back to this category where we suggest just follow up for these patients and just remind and do nothing more than that. But I'm going to mention, and those of you who've done stress tests with Rika for this indication probably know that this is very uncommon that we see an abrupt and clear loss of preexcitation. When Rika sees this, which happens like once a year or every other year, she runs into the office here to show me the one case where we saw that, because it isn't common. And oftentimes what happens is you see something that looks like a little bit of subtle preexcitation and you can't rule it out, so it becomes unhelpful. But if there is persistent or uncertain loss of preexcitation, then at that point, the recommendation is to perform either a transesophageal or an intracardiac EP study. So many of you have never seen a transesophageal study because both Barry and I are not big fans of it, but a number of electrophysiologists do it. Actually, Andy Blaufox over at Northwell, that's his go-to for patients. And so if he's in this circumstance where there's a asymptomatic wolf who has persistent preexcitation, my understanding is that he'll bring them to the cath lab, sedate them, put a transesophageal lead in, and then do a brief EP study. And if the patient passes the study, which we'll go over in a moment, then that's the end of the procedure. And so the advantage of that is that you don't have to put a catheter in the heart or in the vein, and theoretically it should be lower risk. And I would remind you that the esophagus sits immediately behind the left atrium, and so if you place a bipolar catheter in the esophagus and you pace with a very wide pulse width, usually around 10 milliseconds. And just to give you an idea, the bedside pacemakers that we use to temporarily pace people have a pulse width of about 1 millisecond, sometimes 1.5. So you need a very, very wide pulse width, meaning you're delivering the energy for a very long period of time. And so it needs a very special kind of a stimulator. The one in the cath lab would work for this. You can actually pace the left atrium. And just in case you're wondering, you cannot actually pace the left ventricle or the right ventricle from the esophagus. So you can only atrially pace from the esophagus, and it's not that easy to do. You really do need to be in a cath lab setting to do this because you have to manipulate the lead a number of times until you find a spot where you can capture the left atrium. But anyway, whether you're pacing the atrium via the esophagus or via the heart, you then are looking at the SPERI, or the shortest pre-excited RR interval. And one of the theoretical disadvantages of a transesophageal study is that you cannot usually induce AFib from the esophagus. Because if you really go back to that original paper that I mentioned a moment ago by Dr. Klein in 1979, he actually put the patients in AFib, which is, of course, the arrhythmia that we're worried about in these patients. So instead, what we normally do is we either induce AFib if we can, or else we use a rapid atrial pacing as a surrogate for atrial fibrillation. And so if the shortest RR interval pre-excited is longer than 250 milliseconds and the patient does not have SVT, it's saying here that you could follow in cardiology with counseling regarding symptom awareness, which is a 2A recommendation. So not a hard and fast rule, but sort of what most people would recommend. And it says here, you may consider ablation based on the pathway location or patient characteristics as a 2B indication. We'll go back to that in a moment. If, however, the shortest pre-excited RR interval is less than 250 milliseconds in AFib, then basically they're saying discuss the risk benefits of ablation. And similarly, if SVT is inducible, as a 2B recommendation, discuss the risks, benefits of ablation. So they're essentially saying if you have an asymptomatic patient whom you can induce SVT, 2B typically means that most people would not do an ablation for this in an asymptomatic patient, but not necessarily wrong to do an ablation. Whereas 2A is sort of most people would agree you should do it. But if you don't do it, it's not that you're necessarily committing malpractice, but the general approach would be to do this. And most people would perform an ablation in that setting, or at least try to. Now, here's the interesting thing. So these recommendations came out 12 years ago. Since the time of these recommendations, there have been a number of papers that have come out that have basically demonstrated that intermittent pre-excitation and passing a stress test with loss of pre-excitation does not guarantee low-risk characteristics for WPW. And there are, studies showing that a small percentage of people who pass the stress test or who have intermittent pre-excitation do, in fact, with formal testing, either have high-risk characteristics of their pathway or alternatively have sudden cardiac arrest or sudden cardiac death. It's very uncommon, and I'm certain that if you do pass the stress test or you do have intermittent pre-excitation, on average, your risk is profoundly lower than the patient who does not, but it is not zero. And so there is a bit of a change afoot where a lot of electrophysiologists are slowly moving in the direction of ablating everybody, or at least formally testing everybody in the cardiac cath lab because of these small percentages that are being identified. And some have wondered if it's time to revise this recommendation, or at least change the class status of these recommendations. So in this case of this patient who has intermittent pre-excitation, who's asymptomatic, the recommendation was made to probably consider mapping the pathway in order to first of all test the pathway formally in the lab, and secondly to potentially ablate it if it were in a safe location. But I offered the family the option of doing nothing and explained to them that it was perfectly reasonable and in fact consistent with the 2012 recommendations to do nothing in a patient who was asymptomatic, as long as they remained asymptomatic. And I also told the family that I had no objection to them starting stimulant medication in somebody with WPW. Now, here's the next question, which is, where is the accessory pathway in this patient? So why don't we ask Dr. Kalis if she has any thoughts on this matter.
All right. Good morning, Dr. Pass.
Good morning.
Okay,
If
so
you'd like assistance with an algorithm, I'm happy to provide it.
thank you. I think I have the algorithm actually.
Okay, great.
So the first step is to look at lead one and see where the delta is.
And what are you looking at in lead one? And for those in the audience, you're saying lead one, we're looking, is this the algorithm you're using?
Mm-hmm.
Yeah, so this is the
Yeah.
so-called Oklahoma map, sometimes referred to as the Aruda algorithm. And there are a number of these, but you're looking at lead one. So you're trying to see if the delta wave is negative or isoelectric in one, or if in V1 R is greater than S. So what do you think about lead one?
So in lead one, the delta wave is positive.
Okay, so we reject that first statement. And in lead
Correct.
V1 is R greater than S?
No.
No. So now we move on to step two, which says is
Mhm.
lead two negative
Negative.
in the CS, in lead two negative.
So in lead two, it does look like the delta wave is negative.
Well, I think it's possible. I would say to me, it looks more isoelectric.
Yeah.
The S, there
Okay.
is a deep S wave, I agree, and it might be negative, but I think I would say it's isoelectric. So now I will tell you, if you see an obvious negative delta wave in lead two, I've cut off the sensitivity, specificity, and positive predictive value, but this one here is extremely sensitive and specific for the pathway being in the coronary sinus, which is a nightmare for most electrophysiologists. Very difficult to ablate in there for many technical reasons, which we could go over. Okay, so let's assume for the sake of conversation that we reject that lead two is negative. We think it's isoelectric.
Mhm.
So now we go to step three, which is V1 isoelectric or negative?
I think yes, I would call
Right.
it
I
isoelectric
agree.
or negative. Right.
And look at this, look at the difference. We were asking the question, is this negative or isoelectric? So this one sort of looks pretty straight across on the baseline and then goes down. Whereas I think you would agree that it really does look like the delta wave is negative here if we contrast these two leads, right? So we would say, yes, this is a negative, and so that puts it in the septum somewhere. And now we're looking at AVF. Is it positive, isoelectric, or negative?
Looks like it's isoelectric in the
It's hard to know.
I mean, there's like a little positive deflection first.
Yeah, I don't know. It's a good question. I think I might even think it could even be, it could be positive. Let's see. If it's positive, then it's asking, is the QRS axis greater than or less than 0?
And it looks like the QRS axis that we're up in one, down in AVF. So QRS is going to be less than 0.
Right. So that would, I'm sorry, so that would put the pathway in the mid-septal region.
Mhm.
So as the electrophysio, and I agree with that analysis. So good job, Maya. So if you thought the patient's pathway was in the mid-septum, possibly, and by the way, if we're wrong and AVF is isoelectric, then it's left posterior septum. So it's somewhere either in the mid or the posterior septal region. But let's say it's mid-septum. So how this to me, I think, highlights the importance of looking at these types of algorithms when you're making these decisions. So in this case, the decision about how aggressive we're going to go after a pathway in someone who has WPW who is asymptomatic and intermittently manifest, I use the pathway location as a guide in some regards. In other words, if this pathway appeared to be very obviously in the left lateral position, where we know that the risk of heart block and complications in general are very low, then I would be more aggressively thinking about ablating it on the theory that the risk is fairly low for the patient. However, mid-septal region is one of the highest risk locations for the development of iatrogenic heart block. And so that is, so that factor, and posterior septum also is not infrequently associated with either that or with coronary injury. So I would, I think aggressive electrophysiologists would say, let me map it, figure out where it is, and then based on that, I'll decide if I want to try to ablate it or how aggressively I'm going to ablate it. Maybe I'll just use cryoenergy if it's in a dangerous location. More aggressive ablaters would say, I'm just, going to go after it and, just like anybody else. And then finally, a more conservative electrophysiologist might say, you know what, this looks like it could be trouble. The enemy of good is better. This is an asymptomatic patient who is has never had a symptom, has intermittent preexcitation. I'm going to leave it alone and wait till it causes a problem for the patient. And there isn't necessarily a right answer. I'm not sure what the right answer is, but this would be an interesting controversy in electrophysiology. Any questions about this? Guess not. All right. Well, then I think with that, we'll stop for today. Hope you found this of some interest and hope you guys have a good day.
Thank you.
Thank you.
Thanks.
Thank you.